If you're a dentist and you'd like to know how to consistently give absolutely painless injections, how to calm fearful patients, most often without pharmaceuticals, ultimately, a gem proven time and again to be one of the biggest practice and profit builders, then you're in the right place, because that's exactly what you're about to learn, and we're starting right now.
And now, Amazon #1 best-selling author, Dr. Tom, the Gems Guy, Orent.
Dr. Jeffrey Hoos is my guest today. He practices in Stratford, Connecticut. He, his 3 partners, and 25 team members. Dr. Hoos invented the patented H&H impression method, and he lectures nationally. He has placed and restored over 4,000 implants. He is the master of the painless injection. Jeffrey, thank you so much for joining us here today. How are you doing?
I'm doing fabulous, Tom. I have to tell you, it's a real honor to spend some time with you after following you for so many years and actually almost living around the corner from you for a long time.
We were neighbors and didn't even know it until a number of decades later. So I'm going to let you take it away. I am so excited to hear about this. Painless injections it's just such an important topic, so go for it.
Well, you know, it's interesting that I've been giving or talking about painless injections for a very long time. And what's so interesting to me is that a number of years ago, I was working with Joe Stephen, may he rest in peace, and we were doing implant lectures, and we were actually in Las Vegas. And I happened to say at the beginning of the lecture that your #1 practice builder in your practice is allowing your patients to feel comfortable, and part of that is giving painless injections. And there was a guy in the front row, and he happened to say to his friend, "Well, that's impossible." And being so shy and retiring, I sort of stopped the lecture, went over, and I said, "What do you mean it's impossible?" And he goes, "Well, you can't consistently give painless injections." So I said, "What do you want to bet?" He goes, "What do you mean?" I said, "Well, we need to bet." And it was a 2-day lecture on implants. And I then said to the group, "There must be someone here from Las Vegas who's got a practice." Absolutely. I said, "Well, why don't tomorrow you bring some needles and a syringe and some anesthetic, and we'll do a painless injection." And the guy goes, "Really?" I go, "But here's the key. You have to be the patient." And the next day, it was a 2-day lecture, and we were tired from lecturing for the 2 days. And at the end of the day, everyone's sort of milling around. And I'm like, "What's everyone milling around for?" And they go, "Well, we're here to see the painless injection." I said, "Okay." So I had the guy sit in the chair, and I'm talking to him, and I'm doing my thing, which we'll talk about. And I said, "Okay." And about a few minutes later, he goes, "Oh my God, I'm numb." He said, "I didn't feel anything." So then Joe said, "You have to start lecturing about painless injections." And that's how it all started.
That's awesome.
That's what we're going to talk about. We're going to talk about painless injections and what it means in your practice. And everything I talk about is always balancing the art, science, and business of dentistry. You have to do great art based on good science and based on good business. And that's why the listeners need to listen to you, Tom, because talking about practice management and business of dentistry, you can't have a practice unless you're earning money and being able to pay for the things for your family and your staff. So it's all about the balance. So when you go to a lecture or you go to any practice management thing, everyone has practice management tips. And I'm fortunate enough to be with the king of 1,000 gems of practice management tips. So I call them sort of putting the flower petals in the garden, that practice management tips comes in all shapes and sizes. And they're really more tips and tricks. So I personally believe that painless injections are the best practice builder. Now, there's a very famous guy from years ago. His name was Harvey Sarner, and I'm sure Tom remembers him. And he was a tax management guru guy. And I was in one of his courses, and he said, "I'm going to give you all the best management tip you can have. Be nice to your patients." Now let's talk about tax law. You know, and it's being nice to your patients and developing a relationship with them, and painless injections are really part of that. So if earning money is not about flipping a coin. Earning money is to understand what helps build your practice. What's interesting about this slide is that when you look carefully on the left side, this is true, and you look at the right side, that is true, but the truth is in the middle, that we all have tips and tricks, and we all have methods we use in our practice, and the key to it is to do things that are consistent for building your practice. We all make mistakes. We all do things that are quote unquote incorrect. Although I will say there's one mistake that I haven't made in private practice. I've never taken out the wrong tooth. Now, I have referred somebody to have the wrong tooth taken out, but I personally have never taken out the wrong tooth. So we want to be open with each other, and we want to understand that the guy and gal that says, I never break off any root tips, they don't take out any teeth, they've never had an implant failure, then they don't place any implants, and all their composites never have any post-operative sensitivity. It's a lie, it's a lie, it's a lie. And we all know that. So the goal of this is, what do we want to accomplish? Well, we want to administer painless injections. That's what we want to do. Most people, when I talk about this, say, you know what? I don't really need to listen to this because I already do that. Don't ask yourself, ask your dental assistant whether or not, in fact, you are truly giving painless injections. They will tell you the truth. They will tell you the truth. It's interesting that we are what we repeatedly do. Excellence then is not an act, but a habit. So when you develop habits in your dental practice that are consistent, that leads to excellence. That's what excellence is. It is consistently doing good things all the time, so you don't have to think about it, but it's a habit. So I started a thing called the Giraffe Society. And this is a society, and Tom is a member. He doesn't know, but he is. And it's really for people willing to stick their necks out. And when you're willing to stick your neck out, that means that you're willing to share ideas. You're willing to share things that you do in your practice with other people. So I've made myself the president of the Giraffe Society because I'm constantly willing to stick my neck out. And painless injection is really running with the Dental Society of Giraffes. It is really understanding that it's not a wink and a nod. It is really walking the walk. That understanding what you're doing, why you're doing it, and enjoying what you're doing at the same time. So let's all think about being part of the Giraffe Society. So the painless injection did not come out of the sky. And I'm going to share with you a story that is, quite frankly, why I became a dentist. I grew up in a family where dentistry was not particularly important. My mother was very much what's called a Bangor bride. A Bangor bride is someone who's had their teeth removed before they're married so that the husband doesn't have to pay for any dentistry. She's delivered to the husband without teeth. And I talk very humbly about being the child of a Bangor bride. My mother was quite an educated woman, but dentally she was not. And my father didn't know much about dentistry. But one day, on the way to visit my grandmother on a Sunday, I developed a terrible, terrible toothache. And my parents didn't have a dentist. And so on a Sunday evening, my mother drove around Bangor, Maine, where we grew up. I grew up in Old Town, 12 miles north of Bangor, and found a dentist who had his practice in his house, banged on the door. This is in 1957. Yes, I'm that old. And brought me in to see this guy. And I will reveal his name because his name was literally Dr. Savage. That was his name. And I remember the operatory as if it was yesterday. Green room with a green robotic looking device with a thing hanging off of it, and the smell. And behind him was this green cabinet with these long syringes hanging down and these glass vials of blue liquid. And it was a horror show. I was covered in blood. And I remember it, when I think about it, my hair, what little I have, stands on end. And my mother decided, well, I need to go see the dentist now. And I remember crying in the car and throwing up and everything. Terrible dental experience. So when my mother brought me back to see the dentist, I, of course, acted out. And the dentist said, well, I can't treat him. And so I win, right? I win. I don't have to go back. But my mother said, well, we really have to go back. I'll buy you something. I'll buy you a toy. So I became so nervous that I literally could make myself throw up. And so I threw up, and my mother said, well, I can't bring you in with vomit on you. So then we went home. And then the next time we went, quite frankly, I literally went to the bathroom in my pants. And my mother said, well, I can't bring you in like this. So I win. So one Sunday morning, we went to a synagogue breakfast I went to synagogue breakfast with my father, and we had bagels and lox and cream cheese and scrambled eggs. And I had a terrible toothache. My father had made friends with a dentist who worked in where my father worked. His name was Dr. Irving Paul, who was a very famous dentist in the Bangor area. And my father called him on the phone. My father was one of his first patients, called him on the phone and said, Irving, my son has a terrible toothache. And Irving Paul said to my father, I'll meet you at the office. I remember the office very clearly. A brown door, an inner glass door with vertical glass. So now I'm being taken to the dentist. So what do? I revert back to the old behavior. The first thing I do is I throw up. My father says, okay, takes off my shirt, happened to have another sweatshirt in the back of the car, puts the other sweatshirt on. We're going. So then I proceed to go to the bathroom in my pants. And my father says, well, you've got a problem. Takes off my pants, takes off my underwear, turns my pants inside out, cleans off the schmutzik on my pants, brings me into the dental office. This is my father. I get into the dental office, and I remember the room very clearly. And I said to my father, I have to go to the bathroom. So I went into the bathroom, and I proceeded to throw up bagels and lox and cream cheese all over the bathroom. In fact, I was so sick that I literally tore the toilet paper holder off the wall. And then something happened. Irving Paul came into the bathroom and sat down on the floor with me. And it's so interesting that every time I tell the story, I become verklempt. Every single time. And if I'm doing it in front of 300 people or 3,000 people or 100 people, every time I tell the story, it brings back this compassion that Irving Paul had for me. And he said, I know you're in terrible pain. I know you're terribly afraid. If you let me, I will help you. So suddenly, you have this child who is 5 years old, was being exhibited a compassion. It doesn't mean I wasn't afraid, but it was a different level of what was happening. So when we talk about painless injections, we truly need to understand We need to understand, what do patients see, what do they hear, and what do they feel? So what do the patients see, what do the patients hear, and what do the patients feel? We forget that if you walk into your reception area, notice I didn't say waiting room, reception area, and you sit down and you look around, if you have magazines that are National Geographics from 1953 and there's cobwebs in the ceiling, you need to reevaluate. And I think I remember one of the first lectures I went to, Tom, with you, was talking about the Ritz-Carlton experience, and going to brunch at the Ritz-Carlton in Boston. And when you went to the bathroom, what did you actually see? You know, the Ritz-Carlton experience. And every business is the same. Every single business is the same. It's, what does the customer see? What does the client see? What does the client hear? And what does the client feel? So the problem with painless injections is that most people, their experience is, I'm getting a shot. That's what I'm doing. I'm getting a shot. And the problem is that the dental complex is a very different situation than getting, quote unquote, an injection in your arm. And it has to do with lots of physical anatomy things, and it has to do with dealing with the most intimate part of your body. That somebody is coming to the most intimate part of your body and invading it. And so what is really our job? Our job is taking care of our patients, and in order to do that, we have to get the teeth numb, we have to get the tissue numb, so our patients are comfortable. And the name of my practice is the Brush and Floss Dental Center. It's the most mundane name in the world, but no one ever forgets it. It's not about brushing and flossing. It's about taking care of your patients. And in order to do that, our patients have to be comfortable. So to do painless injections, what do we need to know? We don't need to know much. We only need to know anatomy, pharmacology, and psychology. That's all we need to know. And you can get a PhD in anatomy, you can get a PhD in pharmacology, you can get a PhD in psychology, you can go to medical school and become a psychiatrist, and you need to know all of these things. And in balancing the art, science, and business of dentistry, balancing the art is one thing. Understanding the science of what we're doing is also extremely important. And so let's do our anatomy lesson. We all know that it's one of the toughest courses in dental school. At Tufts, it was brutal. Going down into the morgue and being with the cadavers. And one of the first experiences you have, I had never seen someone that had been waked before. I'd never seen it. I'd never seen a dead body in my life. But anatomy lessons, we only have to understand the 5th division of the trigeminal nerve. That's all we have to do. And I don't know about you, but I basically learned it for the test. You know, we all know on Olympus towering tops, we all know the cranial nerves. But learning the 5th division and understanding there are 3 divisions of the fifth division of the cranial nerves, and that there are multiple branches off of them, we need to understand the 1st division, the 2nd division, and the 3rd division. And it's challenging. And if I were to give everyone a test right now and I would say, so can you tell me the nerve to the myohyoid? They'd go, okay, let's see. It's just not something we remember unless you're an anatomist or somebody that's a real great remember of these trivial things. Not suggesting it's trivial. I'm suggesting we learn the anatomy so we can learn what we need to do. And so the anatomy is one thing. So we all have a PhD in anatomy. So now let's get a PhD in psychology. We need to understand what's inside the patient's head. And more importantly, what's the patient's past experience? And every dental patient has a past dental story. When we do our denture course or our implant courses, and someone comes in and they're edentulous, they didn't make themselves edentulous. Somebody did that to them. Most likely a dentist. And their past dental story is not a good one. So the easiest patient in the world is someone who's never had an obnoxious dental experience. That's the easiest patient in the world. People who ski. If you grew up in Maine like I did and you were always cold and it's always icy, until you get to ski on great snow, you don't know what skiing's really like. So it's very important to understand that it is that experience the patient brings to the chair that's incredibly important. That's why when people talk about sedation and nitrous oxide, it's a balancing act between past experiences and personal experiences. You know, one of the most successful companies is Docs, right? Learning triazolam, using triazolam to sedate your patients so that they can come in and have a good experience. Or I used to love reading ads, the yellow pages, I treat dental phobics. You can have all the dental phobics you want, okay? Dental phobia is not something I want to treat. They're difficult patients, and I sedate patients occasionally. But I remember a very famous dentist from New York once said to me, I'm sending you a patient, Jeff, that I want you to treat, but I just need you to know she needs to be IV sedated for her alginate impressions. You know, thank you very much. This is a difficult journey to treat these patients. And I give great kudos to those folks that are doing IV sedation and treating patients. You may have all of my dental phobics, but I like treating dental phobics so that I can change their perception of what's happening in dentistry. And we'll talk a little bit about that. Also, one of my dearest friends puts nitrous oxide in every one of their patients and all of their children. I do not believe in nitrous oxide. I have nitrous oxide in my practice. But when you put nitrous oxide on a child, what you're really teaching them is there can be a better life through sensory change. That is only Jeff Hughes's opinion. But what happens is when a child comes into a dental practice who has had no past dental experience and they have an obnoxious experience like I had, they are now a dental phobic. But when they come into a dental practice and they have a positive experience, which is built on, they are not dental phobics and they don't require nitrous oxide. And I will debate this till the end of the time that I do dentistry. Nitrous oxide is something that is not necessary in a dental practice for the new patient experience. So in 1859, cocaine was isolated from the coca plant and local anesthetic was developed. And procaine by Einhorn at the turn of the century was available. And I just happened to have one of my prized possessions. And I don't know if you can see this, but this is a book that is the Dental Formulary from 1936. And when you turn to the page that says making a tooth so you can basically work on it, they suggest taking sodium chloride tablets, distilled water, boil and filter. Add a drop of superine hydrochlorine, whatever that is, 1,200 parts per million, dissolve in 16 drops of sterile physiological saline solution, which makes a 2% solution, and it's ready for immediate use. And then in 1943, xylocaine from AstraZeneca or Astra was the most significant development. And xylocaine was really developed for wartime use so that they could numb battle wounds and work with them. Okay? So this is from an article, Articaine, Truths, Myths, and Potentials, the Academy of Dental Therapeutics and Stomatology. If you ask most dentists, what is it you use in your dental practice? They will go, I use whatever my dental assistant buys. Or I guess I use lidocaine 2%. Or I use mepivacaine, or I use marcaine, or I use septicaine. And septicaine is obviously articaine. Or I use xylocaine. And so you need to know what you're using. And when articaine first came out, or septicaine first came out, I was giving a lecture to the AO Society of Toronto, and I happened to say to the group, I hope you folks are using this new anesthetic called septicaine. And the guy raised his hand and said, what do you mean new? Like, what do you mean new? We've had it for years. But it took a while for it to get through the FDA. So you really need to understand what it is people are using. And this was an article of surveyed dentists, and of course the most prevalent is 2% lidocaine, 1 to 100,000 epinephrine. And when we look at the chart of anesthetics, and if I were to say to someone, what's the PK value of your anesthetic, and what's the onset, and what's the duration, and what's the maximum dose, most people can't pull that up. And you've never seen anything quite as exciting as to see an allergic reaction or an overdose of lidocaine. It's really quite exciting to see. Most people don't get to see it because people tolerate lidocaine very well. But if you notice that on the right-hand side, 4.5 milligrams per kilogram or several micrograms per kilogram, you can give someone a lot of lidocaine. But if you have someone that's about 65 pounds, very thin, and hasn't had lunch or breakfast, and is quite frankly bulimic or anorexic, you have to be careful about the anesthetic you use. And yet we don't really think so much about it. And we can talk about articaine, and we can discuss articaine, where you can use it, where you can't use it. I don't want to get into the debate of whether you can use it for blocks or not, but it's a very interesting concept or topic. And so we need to understand that I call it the rule of I's, that anesthetics come in esters and amides. And the truth of the matter is that we really only use amides. There are some people that will use procaine, or tetracaine, but the interesting thing about these anesthetics, most of us are using the ones on the right. And so we don't have to think so much about the toxic reactions of using esters. So now, let's get to painless injections. So the first thing you want to do is you want to be very patronizing to your patient. Never patronize your patients. Never do that. In fact, never speak to your patients about important things when they're lying down. Because what's happening is the transactional analysis model of you being the adult talking to a child, the child cannot make a decision. Because you're the adult, you're the superior figure. So if you've broken off a root tip, or you've separated a file or an instrument in the tooth, notice I didn't say break an instrument in a tooth, you've had a file separation. The second person that needs to know that is the patient. And they need to know that sitting up, because you can have an adult conversation with that patient. So never patronize your patients. Also, never think that you're going to overpower your patient. Victory will be mine and I will get you numb, and then you get into a battle. It's like if you have a child that is crying in your practice, you need to abort that behavior. Take the child out of the dental chair. Have the child stand up next to you while you're sitting down. You're now having an adult discussion, even though they are a child. Do not battle with your patient, ever. Once you start fighting with your patient, you lose. You've lost. You've lost. because the patient's one in charge. The patient is who we work for. The patient is who we work with. We do not fight with our patients ever. Ever. The next thing is, when the patient arrives at your dental practice, as I said, the easiest patient is a child who's had no dental experiences. Now, most of them have had doctor experiences, and they've been bad because they've gotten injections. But the worst thing that can happen is when a parent says to a child, "Don't worry, Tommy, Dr. Hoos isn't going to hurt you. Don't worry, Tommy, if you behave, I'll buy you a toy, I'll take you to McDonald's." You have lost. So you need to partner with the patient's parent to have the parent understand. And what's interesting, most of the children we see in our practice, they're referred by the parent because the parent has had a painless experience. And if you did this for my kid, or you did it for me, you can do it for my kid. And therefore, the parent has already come in and said, wait a minute, this is an amazing place. It doesn't smell like a dental office. It doesn't look like a dental office. People don't behave like a dental office. There are no cuspidors. The instrumentation is behind the patient. There are no noxious noises. There are no noxious smells. It's not a dental office. It's a place where we do dentistry. Now, this is a controversial subject. Topical anesthetics. Everyone will tell you, I give painless injections because I use topicals. I don't use topicals. Da 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 da. And I'm going to explain why. I believe topicals are the devil. This is a patient. Now, I shoot a lot of dental photography. I keep a camera with me a lot because those of us who do cosmetic dentistry know that we need to document our cases. And those of you who don't have a camera, you need to buy a good one. You need to buy an SLR with a macro lens, and not only show your befores, but be proud enough to show your afters. You know, when Woody Oakes first started selling intraoral cameras, and we first started talking about intraoral cameras, be brave enough not to show what other guys are doing and other gals are doing. Be brave enough to show what you're doing. It's one thing to show a crack on a tooth, show the repair. As a side note, I had a very interesting experience just last week. I had a very well-known dentist, a very well-known patient who you all know as a new patient. You all know who it is, but I can't tell you who it is because of the HIPAA laws. Welcome to my practice. I hope you had a good experience. I love your hygienist. But you know what I love most about your practice, Dr. Hoos? You don't have one of those TV cameras hanging above me and showing me all the crap in my mouth, because I think it's abusive. Very interesting. She said to me, it's abusive to show me what's in my mouth and criticizing what other people are doing. And that's why I left the last 3 dentists. But I know that you have intraoral cameras. Why do I know that? Because I already know everything about you. But you're not using it as a negative reinforcement to get me to buy dentistry. Now that's a very interesting point of view, and it's really an outlier point of view. And intraoral cameras work, and I take lots of intraoral pictures using an SLR, and I show a lot of befores and afters, but it's an interesting perception. So now, I shot this picture of this patient, and I have no idea why I shot this picture. And it's topical that's being applied for an inferior alveolar block on the left-hand side. And I came back into the operatory after waiting and doing a hygiene check, because quite frankly, applying topical is very cool. You apply some topical, you got some time, you can go do a hygiene check, and come back and give your anesthetic, right? It's good practice management. But I noticed that she was sort of quivering a little bit. And if you notice at the stick, how it's sort of out of focus a little. And I said to her, Robin, what's the matter? She goes, I'm very frightened. I know I'm going to be getting a shot. Now think about this for a second. What the learned behavior here is. Topical leading to a shot. So what's happening is the painless injection concept is there's something called flight or fight. Tom, in your years of practicing, if you had ever come into an operatory, get ready to work, and the patient says, do you mind if I go to the bathroom? Of course you have. The truth of the matter is, if the patient had enough guts, they would run out the door because they have to go to the bathroom because they're nervous. But their social skills or their social upbringing has brought them back to your operatory because they know that it would be inappropriate for them to walk out the door. But in reality, they're frightened. And so it's their social construct that has allowed them to stay. And that's because of your nervous system. Now, this is a wordy slide, and I'm going to read it. The organs of our body are regulated by part of a nervous system called the autonomic nervous system. The autonomic nervous system is part of the nervous system, and it controls many organs and muscles within the body. In most situations, we're unaware of the workings of the autonomic nervous system. Notice I almost said automatic nervous system, because it functions in an involuntary, reflexive manner. For example, we don't notice when blood vessels change, size, or when our heart beats faster, how some people can be trained to control those functions of the autonomic nervous system, such as heart rate or blood pressure. The autonomic nervous system is most important in two situations. One, in emergency that cause stress, it requires us to fight or take flight, run away. And in non-emergency systems or situations, it allows us to rest and digest. Rest and digest, fight or flight. What I say is, the Philistine warrior is coming at you. You have a spear. You have to decide, am I going to fight him or am I going to run away? Or you've eaten a big Thanksgiving meal. If you go out and shovel snow, you're not going to digest your meal. You want to rest and digest. So the sympathetic nervous system and the parasympathetic nervous system is very much intertwined. So let's pretend for a moment that we're going to have to fight the Philistine warrior. Our pupils dilate. We don't have any salivation. And for those that lecture, and if I said to somebody, I was once teasing someone, here, you do the lecture, and they go, my mouth gets dried up, I couldn't possibly do it. You get bronchial dilation, shows you can bring in more air. It inhibits digestion. The glucose is released by your liver. And in many situations, you actually shake because you could lift the car off the baby because you become super strong. Why do you think professional athletes get their sympathetic nervous system in tune? Why do professional boxers? They want their sympathetic nervous system to take over. The parasympathetic nervous system, though, is where your pupils are constricted. You have a lot of saliva. Your heart rate decreases. It stimulates digestion. Okay, it relaxes your rectum. You're relaxed. And you're in a situation of calm. So which patient do you want to work with? Someone that's sympathetic nervous system is firing off or their parasympathetic nervous system? And the way to remember this is, because I'm not a very good student, Papa will take care of you. Your parasympathetic nervous system will take care of you. Painless Injections, 1998, by Quinn. No matter how successful different injection techniques are reported to be, if the patient is anxious, they will be very difficult to anesthetize. Anxiety lowers the pain threshold. When that occurs, the patient will experience non-painful stimuli as being painful. Decreasing patients' anxiety is important as the local anesthetic. Ways to manage patients' anxiety may be through the use of nitrous oxide, oxygen inhalation, sedation, oral sedation, or intravenous anesthetic. Forget the last line. The first thing we want to do is we want to put the needle right in front of the patient's face. Sure, right. The second thing we need to do is we need to watch the patient's eyes. The eyes give it away. If you're examining a denture patient and they're complaining of denture soreness, remove the denture. Take your index finger, run it along the alveolus surface of the denture. Do not look in their mouth, look at their eyes. And they will literally move, their eyes will blink where the sore spot is. Taught to me by a guy named Schwarzwelder in 1976.
That's amazing.
So when you think about painless injections, we want the bear to be relaxed. We want the bear to be relaxed. And we don't want somebody puffed up. We want them relaxed. Relaxed. We want the parasympathetic nervous system to take over. Now, I will tell you, giving painless injection is not magic. If I can do it, anyone can. There is a bit of showmanship. If anyone's ever played liar poker, they put the card on their forehead and they're the one that can't see it. Everyone else can see it, but they can't see it. It's like the famous magic trick where someone's getting rid of something and they're throwing it, and they're throwing it beyond the patient's shoulder, or the what would you call the person who's in the magic show? The shill, not the shill, the dupe, and they're getting it over their shoulder. They don't, because they're doing it this way, they can't see it. So there is some showmanship. The first part of the showmanship is distraction. Take a very deep breath. What happens when you take a deep breath, you can't do anything else. What you've done is, all this time that we've been talking, I don't know that I'm breathing. It's part of my autonomic nervous system, but I can change it. And suddenly my brain goes, wait a second, what's that? What are you doing? What are you doing? You're breathing. Okay, take a deep breath. Also, when you ask someone to look at you, please look at me, look into my eyes, look at my balding forehead, look at me, take a deep breath, and look at me. Suddenly, the brain is getting a tremendous amount of information. Magicians use it all the time. They use it all the time. Extraction, it's like the distraction of it is what makes it work. Also, you must be able to focus on what you're doing. You cannot put up the game-winning foul shot at Boston Garden for the NBA championship with 1 second on the clock in a tie game unless you can focus on the rim. So for that moment, it's only you and the patient. You have to focus. You need to feel free. You can't live your life unless you're focused and understand. And if you look at this carefully, there's a lot happening in this slide that you can get at, but you have to focus. You can't listen to what's going on in the hygiene room. You can't think about what's happening with the stock market. You can't decide that you're hungry. You have to focus. because if you don't focus, what happens is it's all so convoluted that you can't figure out what you need to do. So for that millisecond, you need to take a breath yourself. And you need to focus. And I will tell you something that I do before every surgical procedure that I do. And I actually told somebody, I was giving a lecture in Israel, and I had someone tell me later that it changed how he practices dentistry. Dean Shira, on our first day in 1975, said, "Gentlemen, and you three ladies, gentlemen and you three ladies, you are going to be given the right to cut human tissue." I found it extremely profound. That only priests were allowed to cut human tissue. So every time I pick up a scalpel blade, I think for a moment, I've been given the right to cut this patient and make them bleed. It centers you, it focuses you. So the concept of focusing is extremely important. You have to focus on what you're doing. And when I go back to talking about the ability to cut human tissue, you have to focus. Now, it's all in the timing. It really is in timing, and we'll talk about how it's done. Now, it's very funny that you think that this is a no-brainer. The needles have to be sharp. What's very interesting, going back to this dental formulary book, it says that put your needle through a cork and run it over a file to make sure your needles are sharp. Really? The concept of using disposable needles is very interesting to me. I keep at least 2 syringes for whatever I'm doing because I don't reuse my needles for my initial injections. So if I'm doing an injection in the lower left and I use one of my syringes and I happen to be doing the top left also, I pick up another syringe because I know that that needle is somewhat dull. Believe it or not, it's somewhat dull. Now, what's interesting, over the years, I happen to find this. This is a device that was put on the market to allow you to do an intraosseous injection by hooking it up to a handpiece and drilling into the bone and having the anesthetic automatically dispensed into the bone. That's quite exciting, isn't it? That's quite exciting. And quite frankly, that's a torture device. Also, there are devices out there called a Vibrojet. There are people who love them. They work quite nicely. It's a vibrating syringe attachment, reduces pain levels on receiving intraoral injections. It's something else for me to buy. I tried them. Joe Stephen gave me one. I don't use them. The wand, very efficient in some doctors' hands. I was given one. It sits on the shelf, right? If you have it, you love it, your patients love it, that's great. That's terrific. What's interesting about the wand is it's only been introduced about 3 times by 3 different companies. There are lots of different gadgets. It's like a multitude of Swiss Army knives. There are lots of different gadgets. If they work for you, great. But dentistry and making money in dentistry is not about having lots of stuff. It's about introducing things that reduce your overhead incrementally. I wanted to reduce my overhead by 10%, so I'm going to fire 3 of my staff members. The way to introduce or reduce overhead is incrementally 0.5%, 0.25%, 1%, and work on that to get to 10%. It's not cutting off the legs of your dental practice.
Jeffrey, it's funny. I love the fact that you mentioned reducing overhead. And yeah, we got to be careful. Avoid cutting things that may actually end up hurting net profit. That said, reducing overhead the right way can have an amazingly positive effect on your net profit. What's the effect on the net profit, your income, when you reduce your overhead by 10%? Well, let's say your overhead is 70% of collections and you keep 30 cents on every dollar. If you reduce your overhead from 70% to 60%, that extra 10 cents you're keeping on every dollar collected, that represents a 33% increase in your net income. Well, what if your overhead is 80%? You're only keeping 20 cents on each dollar, so reducing your overhead from 80% to 70%, or keeping an extra dime for every dollar collected, that's a 50% increase in profit. Doctor, whether you're watching this during global recession or financial boom times, you'll take home more net profit after you read my free special report, 4 Ways to Get Your Overhead Under Control and Boost Your Net Income. It's less than a 10-minute read. Get your free report at freegem1.com. That's freegem, then the numeral 1.com. There's a link in the description below. Thanks, Jeffrey. Please continue.
So, painless injections. You have to talk to your patients. Now, it's a little more difficult with a mask in front of you. I understand that in times of COVID, but you're talking mostly with your eyes, okay? And I never before gave injections with a mask on. I'm not producing aerosol. I didn't have to worry about that. I'm doing a transactional analysis or transactional interaction. I always see my patients sitting up or at the same level as I am. So I want to talk to my patient. I want to be understanding, but I want to be in control. I want to be in control of the situation. I also want to understand what I'm trying to accomplish. Why would I give an inferior alveolar block if I'm going to do 2 lower incisors? Why would I do that? I want to be confident in what I'm doing, but I also need the right tools for what I have to do. I need the right instruments. I need the right tool. So let's get numb. This lecture or course was really a hands-on course for many times. We can't do hands-on courses, so let's get numb together. Painless injections. Let's talk about infiltrations. Are we going to use topical? No, we are not. Are we going to use carbocaine, septicaine? And what teeth can I get numb this way? What teeth can I get numb by doing infiltrations? A lot of people will tell you that you can get every tooth numb by infiltration. And I would agree with that. But it depends on what you're going to be doing for that tooth or that space. When I do my implants, I never, ever give a block, ever. Why don't I give a block? It's part of an implant course, but I want to know if I'm getting close to the inferior alveolar nerve. And I only have to numb the tissue. So therefore, I don't need to numb the bone. And therefore, I'm not going to give an inferior alveolar block. Now, if I'm going to be taking out a quadrant of teeth, I might consider giving an inferior alveolar block. The concept of septicaine, remember, the higher the concentration of the drug, the greater the toxicity. Septicaine is 4%. What else is 4%? There are other anesthetics that are 4%. So if I have a thin, blonde, blue-eyed woman and I give a lower infiltration, there is a likelihood that I'm going to get some bruising. So therefore, I need to tell that patient what to expect. Mepivacaine is a local anesthetic of an amide type. Mepivacaine is reasonably rapid onset, more rapid than procaine, medium duration of action, shorter than procaine, and is marketed under various trade names including carbocaine and polocaine. You need to know what you're using. Again, understanding what you're using. Inferior alveolar block. Am I going to use topical? Am I going to use carbocaine? Am I going to use septicaine? Am I going to use lidocaine? That's a decision up to the doctor. Not up to the detail salesperson that sells you dental supplies. It's up to you. You are a doctor. My mother-in-law would tell you not necessarily so, but most people consider dentists doctors. You know how I feel about topical. I'm not using it. Here we have a lower anterior that we're going to get numb. Notice we have attached gingiva and we have mucosa. Where are we going to put the needle? We're not going to put the needle into the attached gingiva. It's too uncomfortable. What we're going to do is we're going to introduce the anesthetic into a site where we want the patient to get numb. Look at what you're seeing here. You're actually seeing post-injection. A few seconds later, okay, there's the needle, there's the site. Giving or introducing some anesthetic into a site and waiting gives you the great advantage of what you want to accomplish. Here's the trick. When I take the needle and I bring it to the tissue, what I do is I do not push the needle into the tissue. Because when I do that, the tissue moves and then the needle goes through. The needle is brought to the tissue and the tissue is pulled to the needle. The needle is brought to the tissue is brought to the needle. Part of the distraction is the gross movement of the lip. But at the same time, Sally or Mrs. Jones, look at me, take a deep breath, and then the tissue is brought to the needle. 3 things are happening. Deep breath, look at me, tissue brought to the needle. And then slowly deposit your anesthetic. There is the site where the blood is coming out. Also coming out of there is some of the anesthetic. So you want to have some suction or use a gauze to sop that up because it has a bad taste. The bad taste is part of the noxious stimuli you don't want the patient to have. Let's do an inferior alveolar block. When you take your hand and you put it into the patient's mouth, you bring your finger, take your finger, go down, and you will feel a notch in your jaw where the facial nerve and the facial artery comes around. Find that notch, push on it, bring your finger into the patient's mouth, pull the tissue taut, pull the tissue taut, pull the tissue taut. Get ready with your bevel facing which way? Towards where you're working. The red dot on the inside of the needle is there for a reason. It shows you the bevel. Bring your anesthetic syringe to the tissue and move the patient's face when you tell them to stretch open to the needle. And wait. 1, 2, 3. Look at me. Look at me. And slowly deposit your anesthetic. Look at me. Now, take a deep breath, stretch open, and the needle comes out. It is so routine for me, you need to practice this, just as you have to practice a magic trick. Invariably, the patient's looking at me like I'm out of my mind, unless they've been a patient of mine for a long time. And I go, how are you feeling? And they generally go, I didn't feel anything. So now, while you're talking to the patient, you can go back and you can do whatever you want. with whatever technique you want, because why? The patient is starting to get numb. So if you use a rapid onset, like mepivacaine, which is rapid onset, the tissues are already numb. Do we use the same syringe? It is better not to use the same syringe because the syringe is already dull and you're wounding the tissue. You're wounding the tissue. Also, what is bizarre that I have seen many times, someone takes a syringe, they put it in the patient's mouth, and then they move the syringe around. If you think for a moment that you're moving that needle in the tissue, you've lost your mind. Of course you're not moving the needle. You have a chance of breaking the needle off, but you're not moving the needle anywhere. Just know where you're going to go and go there. While the patient, take a deep breath, look at me, move the patient to the needle. Move the patient to the needle. So what have we done? Well, what we've done is we've demonstrated a consistent way to deliver painless injections. The #1 practice builder for your practice, really based on balancing the art, science, and business of dentistry. So if we remember to focus, if we remember what anesthetic we're supposed to use, if we remember what we're trying to accomplish, and we practice, then you will see that balancing's easy. Patients travel very far because Dr. Hoos doesn't hurt them. So when you think back to that little boy throwing up in a bathroom and having a compassionate dentist sit down in the vomit with me, my mother had a cut and paste that said, I want to be a dentist. I've wanted to be a dentist since I was 5 years old because I fell in love with my dentist. I fell in love with my dentist. I'm proud to say we have about 7 people, children, who became dentists because of me. It will change how you practice. All you have to do is be willing to stick your neck out and try it and be part of the Giraffe Society. And there you have it.
That is nothing short of amazing. A number of comments. First of all, my 2 older brothers, unfortunately, were the victims of a dentist similar to Dr. Savage. I was young enough in that although I met him, I was too young to really need much of anything, and so I was spared. But my oldest brother is still a severe dental phobic. So I relate to your story, your compassion, your techniques, the magic with which you deliver your injections is magical. It's amazing, and I love the gem that you made of it. In other words, you made it very simple, very straightforward, and very systematic. Could you share with us a little bit about dental insights so that people can continue the conversation with you?
Well, thank you, Tom. I've been very fortunate to be able to lecture mostly around the world. And it was based on developing an impression technique that eliminated cord called the H&H impression technique. And it was promoted by Ray Bertolotti and Joe Stephen, may rest in peace. And then what happened was I was asked to lecture in front of a study club very early in my career. And I said, well, what is it you want me to talk about? And they said, and the guy's name was Larry Dahm. And he said, you've been in private practice for 1.5 years and your parking lot is jammed. We want to know what you're doing. And I was thinking a lot about it. And I started doing painless injections in dental school because I decided that I was going to figure out a way to deliver dentistry as painlessly as I could. And I really worked on the technique a lot. And so and I'm a full-time practicing dentist. I practice 160 days a year. I have a staff of 25. There are 3 of us. We are open 6 days a week, 4 evenings a week. I am a fee-for-service dentist. I do not participate in any insurance plans. I'm lucky enough that people travel from around the country to see me. not because I can do better dentistry than anyone else. It's relationship building. As you know, Tom, it's relationship building. When the COVID thing happened and 6 of my lectures were canceled, and I don't depend on my lectures for my income. I do it because it's fun and I like doing it, and I've met a lot of great people along the way. You excluded, Tom, but you know. and there's a real camaraderie among us lecturers, isn't there? It's truly a camaraderie. We see each other, we share war stories. And I thought to myself that I would start a dental Facebook group by invitation. And I decided to call it Dental Insights. Because what I wanted to do was I wanted to share some of my insights to try to help people build the practices that they want through sharing insights and sharing tricks and tips. You know, how do you get that root tip out? How do you give painless injections? And so if you go to Facebook and you type in Dental Insights, you can find the site. You have to answer 3 simple questions. All of you know the answers to them. And it's a closed group. And the key to it is posting techniques and methods that make it easier to do high quality dentistry. And the catchphrase is balancing the art, science, and business of dentistry. You know, producing beautiful dentistry is easy if you have all the time in the world. I gave a lecture in New York, and this guy came up and he said, it takes me all afternoon to do 4 onlays. And I said, really? He said, yeah, because I'm a perfectionist. And I said, you know, that's great, but do you make any money? And he goes, it's not about the money, you know. I go, oh, okay. I married a rich girl too, but the mother-in-law's keeping it all. I mean, the point of it is we have to earn money in dentistry. And then I said, but there is someone else who cares about taking all afternoon. The patient who's had their mouth open all afternoon. Because there's a balance there. So Dental Insights, the whole key to it is for us to share these things that we know. And Tom, you were gracious enough to be part of this group, and I appreciate it so very much, because the gems that you've given us over the years for free, that alone can help build a practice. So it's thrilled to have you. So there are a lot of people out there, some of them famous, some of them not so famous, and my goal is to build the group. So I have 900 members now. It was started just before COVID, and I'm hoping to build a group. So I invite you all to come out to Dental Insights. Don't be a lurker. Be a sharer. Be part of the Giraffe Society. Share what you know. And by doing that, you're going to build your cadre of your tips, because no one can do this alone. No one can do this alone.
Jeff, again, I really appreciate your taking the time and sharing. That was beyond amazing. It was beyond all of my expectations. I learned so much. Thank you so much again.
Tom, thank you so much.
I hope we can do it again someday in the future. And thank you so much for joining us in the Dental Goldmine. And remember, you're only one gem away.